So, good afternoon, all. Today, we'll be having this very interesting IC called the Glaucoma Kaleidoscope on evolving patterns, redefining management algorithms in glaucomas of Asia. We have with us Dr. Arun Kumar Narayan from Singapore, Dr. Siddharth Dikshit from LVPI, myself from Delhi Mulanad Medical College, Dr. Sunita Dubey from Dr. Shroff Charitable Eye Center, Delhi, Professor Sushmita Kaushik from PGI, Chandigarh, Dr. Anujun, my co-faculty, and Dr. Arshi Singh, my co-faculty. So over to you, Dr. Sushmita, to cover the very interesting topics on phenotypes in congenital pediatric glaucoma dictating treatment decisions in Asia. Where would she take it, here or there?
Thank you so much, Dr. Kirti, and thank you for the opportunity for this IC. So I'll be talking about why does a phenotype in congenital glaucoma matter. So childhood glaucoma is very similar on the surface. It has, all C's look the same, but believe me, there are myriad hues underneath. And as for all glaucomas, childhood glaucoma is not one box into which all the children are kept. So at the outset, I'd like to say that we do take informed consent from the parents because I tend to show identifiable pictures of the babies because that puts it in context. So in today's next 10 minutes, I'll just describe what we've learned along the way, and I'm sure we have a long way to go. And we'll have snapshots of phenotypes and one or two pearls on the importance of phenotyping. Why is it that you should do that? So coming to one of the pediatric glaucomas when you do them, if you have acute eye drops. If you have a parent or a mother saying this baby was perfectly fine 2 days ago, or dekho aaj kya ho gaya, in the ER, inward you're saying now it's good because you're going to be God. And if you see that, can I have a pointer? Aapke paas hoga? If you see that on the right side, that's the Harb striae which has really stretched out, which is why the aqueous has gone straight into the eye. And you have the acute eye drops, and the picture on the bottom is actually how much they cleared with just giving an anti-glaucoma medication. So this is with dorzolamide. And you do a combined trab with trab, and it's a miracle. Within 4 to 6 weeks, it absolutely clears, and you really become God. The importance of this is not just understanding that you have to do it early before scarring sets in, but also the fact that we've also noticed that acute eye drops happens in the contralateral eye once you do surgery in one eye. And we saw many children with this, and it changed our practice to treat both eyes simultaneously. But this was pre-COVID, of course. COVID has taught us to do bilateral simultaneous glaucoma surgery for all our babies, and now, so this really doesn't matter. But at that time, when we saw acute eye drops, you did one eye, and he came back with the next, and then you did both eyes. We did well.
Audiovisual, please put the timer on. The timers are not on.
Right. So going further, now that we are in the era of MIGS, and I can say I'm a very happy gatter. So we wondered whether we could do this in acute eye drops, and actually, sometimes you realize that even though this is so hazy, superinasally, it's still a little clear. And we'll just take you through the next couple of seconds that we manage the goniotomy, you manage the proline, and as you go in, actually, you might actually get away with a GAT in acute eye drops. So that's a learning for us that all white corneas are not amenable to angle surgery. If you can manage a GAT, even in an eye like this, they do clear quite well, and they clear as miraculously as a CTT. Coming to neonatal onset congenital ectropion uvea, it is the most horrible glaucoma that we know. These are what these children look like once you do the surgery. There's ptosis, there's a pannus, and there's a spindle-shaped corneal opacity, which Dr. Ken Nischel has described as CYP1B1 cytopathy. We described this phenotype in neonatal onset glaucoma, which were hitherto all PCG. It's not true. You can see that ectropion. If you see ectropion UVA in a newborn baby, you can be sure that you're in trouble, because that's a really, really bad glaucoma to have. This is the same baby that has come after the surgery. And we also actually identified a common genotype in all of them, the arginine 398. So it's also a genotypic marker if you have this phenotype. Prognostication is important, and it's important for you to know that these corneas are never going to clear. They'll either land up in an optical iridectomy, like this child here, or they'll land up in an OPK, which is another ballgame in itself. So this baby really started our rubella journey. UBM, if you see a zonular cataract, you have to think rubella, and when we started doing the rubella testing in our neonatal babies, the hallmark of the phenotype is a small eye, white cornea, high IOP, and optic disc cupping on ultrasound. And if you see this triad, this phenotype, you have to look for a cataract, you have to evaluate hearing, and you look for cardiac defects, and you'll be surprised at how much we miss and how many of these children grow up to be developmentally delayed when actually they just can't hear. Congenital primary aphakia is important to recognize, because to avoid the disaster that I had before I recognized this, the silvery blue hue, and once you start recognizing them, you'll realize you have many, many more in your clinic. Don't just dump them as an anterior segment dysgenesis, first do no harm. There will be an absence of a lens, but believe me, once you recognize what they have and you recognize that they just don't have a lens, you give them high plus glasses, and they actually see, and they are mobile. And high plus doesn't mean plus 10 or 12, it means plus 14, plus 17 sometimes. And they walk around, they are fine, and they'll hate you taking their lenses off. So recognize this condition so that you can rehabilitate them better. This is my pet peeve now. Is aniridia a disease, or is aniridia a phenotype? Is aniridia absence of iris and disease, or is it just that absence of iris? So this is Gardner, usual aniridia, and autosomal dominant, so the entire family, all children and the mother have aniridia. You have foveal hypoplasia, you have a smallish eye, and you have limbal stem cell deficiency, and of course you have PAX6. So if you have PAX6, autosomal dominant, that's that. So here is a preterm, and all of us think it comes white. You do a combined trab with trab, there's aniridia, there are stumps of the iris on the UBM, and you think you're fine. You get a genetics done because the family wants it, and lo and behold, it's FOXC1 complete gene deletion. And you learn that a complete gene deletion of FOXC1 is an Axenfeld with no iris formed. And when we look further, now the child has grown a bit, you can see the telecanthus, you can see the periumbilical skin, which you didn't look for because you just assumed it's aniridia. And these children don't need Wilms tumor screening at all, simply because there's absence of an iris. Now what about this? Again, a 2-month-old, absence of iris, no iris at all. Is this aniridia? Yes, we thought it was. So this was also named aniridia, except that it was just absence of iris. Did a bilateral combined trab with trab? Well, lo and behold, CYP1B1, arginine 398. We didn't recognize a CYP1B1 cytopathy. This was neonatal onset CU with severe iris hypoplasia. If you have absence of iris and no nystagmus, it's good, because then it's not PAX6 aniridia, there's no foveal hypoplasia, there's no limbal stem cell deficiency, and there's no risk of Wilms tumor either. And they are not autosomal dominant. They are all autosomal recessive diseases, so it's likely that the child might be a carrier. You have some hope for this children. So to summarize, I think clinical examination is a hallmark of management of childhood glaucoma, and why childhood glaucoma? It's a hallmark as for all others. Ensuring good vision is our goal and not just IOP control. Look out for the family, but remember, once you start taking care of these babies, you need to hold these children's hands lifelong. But it's been a pleasure, and it's been really, really nice to be able to be a part of their lives. I take the opportunity to thank, these are from Deepika to Faisal down, all my senior residents who work hard, really, really hard, so that I get where I am. And I invite you all to the Indian Pediatric Glaucoma Society. This time it's at Madurai in December. Believe me, you'll see a lot more of these stories as all of us tell our tale. Thank you.
Thank you. Yes, yes, please. Dr. Sushma has a comment for you, and Dr. Siddharth, you can just load your slides. Mike, please.
Hello.
Yes, sir.
She has mentioned about congenital rubella syndrome, and that is a totally preventable syndrome. If we vaccinate all children, or if we vaccinate all adult females who are going to be married, or just before married, or at the time of rope or ring ceremony, then we can prevent congenital rubella syndrome. Because if rubella happens during first few weeks of pregnancy, 90% of the children they will be born with congenital rubella syndrome, including congenital glaucoma, congenital cataract, microphthalmia, choroidititis, besides other heart and other abnormalities. So that's why I wanted to say.
True, I agree, yes.
For 5 minutes so that we can have a group photo because both of you have to leave.
Okay.
So just have a group picture before you go. Yeah. Please, Dr. Siddharth Dikshit from LV Prasad Institute. I believe there's a goof up. There's you. Yeah. Just you'll be speaking on evolving paradigms in MIGS and tubes in angle closure disease. Over to you.
Thank you so much, Dr. Kirti, for making me a part of this wonderful group. And I will focus on whether you have enough space in angle closure to be able to perform a mix. And happy to be a part of this wonderful group of stalwarts. I will also be touching upon just briefly on a few tips about implants in angle closure. And now, when we talk of this topic, why do we think there is a challenge especially related to MIGS? First thing is whether you have access to the Schlem's canal and whether the iris root is visible or not. That will depend on the extent of the peripheral anterior synechiae, how large is the lens, how is the lens vault, and whether you are taking out the lens before you perform the MIGS or not. The iris in our eyes is different. While you see the Western eyes accepting sutures, trabeculectomies being performed without PIs, our iris is not like that. So you will have much more inflammation. There is much more higher chance of spas forming, and goniosynechiolysis is not been as effective as it has been in the other populations. Also, a lot of our eyes have persistent closure after PI and even after cataract surgery because of plateau iris syndrome. So just goniosynechiolysis may not work there. So with so many challenges there, is it even worth performing MIGS? I believe if the schedules were drawn just a week back, looking at this review article, I would have not needed to give this talk. This paper has just been published for me to pull everything out from there and present before you. The wonderful thing about this paper is, this review meta-analysis is, they have excluded 43 papers and included only 12 high-quality papers, 3 of which are randomized controlled trials. Now, with every paper that we read on MIGS, which support MIGS, we have been talking about where is the RCT, where is the evidence, what is the quality of evidence. So we have some evidence here. Let's look at that. But the meta-analysis showed that when you combine MIGS with phacoemulsification, you get a 10 mmHg drop which persists over 2 years. So all these studies have significant follow-up, and the number of medications reduces by 2. And this is seen across the kind of MIGS that is being performed. Of course, it is higher for some rather than being equal in all of them. Now let us just look at the 2 randomized controlled trials. The first one from Song et al. It was a multi-center trial. You can see the names that is involved here, big names across various nations. And what they did was randomized 124 eyes, 65 and 49 to phacogoniotomy with a Tanito hook, and 59 to phacotrabs. So they are taking up not only phaco but phacotrabs. And as you can see that the baseline, with a similar baseline, they have also presented the per protocol and intent to treat analysis both, and they see a significant difference in IOP at 12 months in both the groups, which is similar. So phacogoniotomy is working as well as phacotrabeculectomy in both intent to treat and per protocol analysis. And you can see that in these graphs also. Of course, the number of complications that you have had in the goniotomy group were lesser than that in the phacotrabeculectomy group. Another study from group in Egypt which has published a very good paper with successful outcomes after GATT and phacotrabeculectomy versus, phaco versus phaco and GATT. And you can see that the success rate is much higher and the number of patients who are off meds at the end of 1 year is also much higher, 75% versus 42%. So phacogoniotomy or phaco-GATT, they work as good as a phacotrab in angle closure and much better than phacoemulsification. So what about ECP? I believe there are some studies which have published good result, and especially in plateau iris it may have a space. What is our experience? So this is not evidence till it gets published. So this is experience rather than evidence. You can see this patient with uveitic glaucoma of a very recent onset viral etiology, uncontrolled intraocular pressures. Now, this is not how you should be doing a goniosynovial lysis. I am using an MVR. I got away with it. If you land up into a hyphema, please don't blame me for it. I'm spreading the wrong word. And if you have access to even 2 clock hours of the angle, the Schlemm's canal, you can actually start doing a GATT. This one actually got stuck and I had to kind of do a twin pass. And as you see here, this is taking time. So instead of a 4-5 minute GATT procedure, you can actually, you will need much more time. And at the end of it, because this was a phakic eye and you need pilocarpine to start acting right on table, I have injected pilocarpine here. In milder cases, I prefer to do either a bang or KDB goniectomy. And you can see here the trab meshwork being peeled off very successfully and easily. And because the angle was quite open, this was a PAC, not a PACG. And on retrospective analysis of 48 eyes who followed up for at least 6 months, the success was defined as 21 millimeters or mercury less intraocular pressure, along with 20% reduction in IUP, along with reduction in 2 AGMs. So all these 3 criteria had to be fulfilled. And out of 48, 23 had greater than 1 year follow-up. 95.8% of the eyes met the success criteria. Most of them had combined phacoemulsification. Intraocular pressure reduced from around 23 to around 13, the mean intraocular pressure. The medications reduced from around 4 to 1. And 85% of patients had intraocular pressures less than 16. 65% of them had intraocular pressures less than 14. 23 out of 48 eyes were free of medication. 2 eyes, however, needed further glaucoma surgeries. In my opinion, and I take full responsibility that this is only my opinion, not all angle closures are same, and before considering a MIGS surgery for these patients, you should look at the degree of plateau iris, degree of PAS, whether it's a plateau iris or not, the contribution of the lens, how much is the phacoemulsification going to contribute, and the extent of disc damage, because your target IOP has to be met, which may not always be the case with MIGS. There is a lot to promise, and the advice is to combine it with phacoemulsification. If you do a minimally invasive bleb surgery, perhaps it may be a good idea to use an iridectomy also. Implants, I would say, may not be a very good idea in our eyes. Now, moving to another set of implants, the biggest challenge that we usually face when we perform a surgery in patients who have angle closure is going and hitting the iris. Now, despite whatever you do, because you're trying to go into the sulcus or sometimes in vitrectomized eyes, even behind the intraocular lens, you are likely to hit the iris. So, you, instead of going and changing your track, one simple thing can be to actually go and cut the iris wherever it is hitting the iris using a vitrector, or as you see in this video, just a simple micro scissors, and that can give you access to the anterior chamber and establish a good flow. This hitting of the tube, the tube hitting the iris may not always be avoidable if there is extensive PAS. Also, a lot of eyes like long-standing angle closures, patients with plateau iris, patients who have had previous aqueous misdirection, and if you have a non-valved implant and you are removing the ripcord, may have shallow ACs which may predispose to aqueous misdirection. So do not forget strong cycloplagia with atropine and probably combined with iTrop plus. So opinions and RCTs are always invited. Thank you so much.
Thank you. Could we request for a group photo? So because two of our instructors had to leave for their simultaneously running ICs. मेरा बीच में था
Can I have my slides, please, Dr. Arshi Singh? Yeah, all right. So we'll be discussing the effects of ocular surface alterations in glaucoma management. The coexistence of the disease with the as a consequence of the glaucoma treatment, and because it is pre-existent, the glaucoma treatment, how it causes the OSD, and the management modalities. So what we know of so far is that anti-glaucoma medications cause increased pro-inflammatory cytokine secretion, interleukins, TNF factors, and other interleukins as well, alters the tear film, and also decreases the corneal subbasal nerve fiber layer density. So what happens because of this is, a consequence of this is all relating to your ocular surface disease. So you can see there are multiple studies that have actually studied the prevalence of OSD in glaucoma patients, and also as an overlooked side effect of the glaucoma treatment, and the measurement of the interleukins and the cytokines in such patients. So what we know is pre-existently also, in glaucoma patients, the rate of OSD is very high. As you can see, it is around 48 to 59%. It's just based on the symptoms. And based on the signs, you can find it in around 80% of the patients, which is a significant proportion of our patients. More than 3 months of therapy is known to cause a state of subclinical inflammation. We'll talk about why this is clinically relevant to us. And the risk factors for OSD are the female gender, elderly patients, pre-existing dry eye disease, the number of medications and frequency of medications, and whether preservative is used or not. On examination, we can use the dry eye profile that we do, the TBUT and the Schirmer's test, and meibography as well. And studies have shown that all parameters have been affected in glaucoma patients. This also, in turn, relates to a poor quality of vision, quality of life, and poor patient compliance, because patients would not want to put their drops. The prevalence of the OSD in glaucoma patients has been linked to the number of back-containing eye drops. The different medications can cause different side effects. For example, drug-induced dermatoconjunctivitis, as you can see over here, commonly seen with the post-prostaglandins that we use, follicular conjunctivitis. We have impairment of corneal wound healing and conjunctival wound healing, limbal stem cell deficiency, and rarely we can also have a pemphigoid-like picture. So what was seen was, perioperatively, the conjunctival inflammation was linked towards the trabeculectomy outcome. They saw that the mast cells and the HLA markers, goblet cells, had decreased and altered in numbers in patients who had preoperative conjunctival inflammation. As we said, almost 80% of the patients already had it who were on glaucoma treatment. On the corneal spectrum, we saw corneal punctate epithelial erosions. We saw patients with burning sensations, anesthesia, and as we know, the netoacidal-associated reticle corneal edema has been well talked about, and tear film alterations as well. Also, meibography showing dropout areas. Besides the glaucoma drugs, what's the culprit is the preservative that we use. Also, as additives in surgery, we use antimetabolites, and the surgery per se causing the conjunctival elevation and thereafter causing the tear film instability and suture-related problems. Also, whenever we do an adjunctive procedure, that can also alter the corneal surface, only a conjunctival surface. So the mechanism is because of the direct toxic effect, or because of interference with the tear film resurfacing, or because of a predisposition to the ocular infections, which is another subset of patients that we have. You can see over here, this is a profile of patients. You can see a delin that has formed over here because of overhanging bleb. Because of the poor healing, you can see that there's a sedal positivity. Because of tight sutures over here, you can see that there is a lot of astigmatism that caused patient to have decreased vision. And as a flip side, as we said, there's a mutual relationship. Preoperative conjunctival health determines the postoperative outcome, and the number of medications that you're using and the pre-existing disease also causes the issues in glaucoma management. So it has to go hand in hand. What you do is first evaluate all patients of glaucoma for coexistent dry eye. These are the tests that we often miss in our glaucoma clinics. Please try and incorporate this into your armamentarium. Make the patient have a fluorescein staining and undergo a Schirmer stress as well. Also, you can perform an OSDI questionnaire and tell the patients to rank according to their symptoms. Initiate the dry eye therapy early, not when the patient starts complaining about it, but when you actually see it on the signs. As I told you, 80% of our patients already have that existing disease. So try lubricants. Try using preservative free when the patient is affording. We understand that there is economic problem and affordability issues for a lot of patients, but wherever option is there, use preservative drops. Use immunomodulating agents. Cyclosporin, Restasis, 0.05% has been known to have wonderful effects, especially in patients with severe dry eye disease or severe OSD disease in glaucoma, and it has been known to increase the compliance and quality of life. Role of diffitigraph is something that's been studied now. Punctal occlusion is something that can be performed, and also low-dose steroids for patients who are non-steroid responders. In these cases, the conjunctival health improves. This is something of particular importance, especially when you're planning the patient for a surgical procedure. Also target the medication. Use a preservative-free drug. We've been talking about Purite, Sofzia for the longest time. Decrease the backload, which means switch to a combination therapy. And if there's a severe allergy, go for an AGM holiday. Stop it and switch to oral medication for a while and use steroids for the conjunctiva to heal. Now, because of the newer developments, we have novel delivery systems, we have the intracameral depots that are there, like the Durista, and under trial, we have bimatoprost AIOS-TR is going to come up, we have other drug-eluting punctal plugs as well, and also you can use SLT in the primary initial therapy. In our patients, we tend to see a response that fades off very early because of the higher pigmentation of the iris, but the light studies showed that it had some good effect in the initial therapy, so that can be tried initially in patients in dry eye disease. Also, as Sir just talked about, MIGS is something that we should opt for early in patients with OSD. Surgical management tips, what we would like to discuss is because of severe OSD, because of surface alteration and that subclinical inflammation, there is a lot of fibrosis in the conjunctiva. So what is important during surgery, be it a glaucoma filtering surgery, a valve, or a mixed procedure, is when you're using the conjunctiva, for example, is remobilize the scar tissue. Make sure you remove all of it, meticulously perform a dissection, use a mitomycin or an antimetabolite if needed in that area. Release the conjunctiva for advancement, for closure of your flaps by using the incisions at the fornix, which are called the relaxing incisions. If you have a very friable and thin conjunctiva, especially one that bleeds on touch, especially in valve cases, try not to use sutures and use fibrin glue instead. Use limbal-based approaches instead of using a fornix-based approach in patients where you find there's a lot of scarring at the area of the limbus. In conjunctival scarring with gaping, for example, after surgery, what you can use is initial cases, you can give them contact lenses, autologous serums, the role of systemic doxycycline is there. If that fails, go on for surgical procedures like putting a layered AMT, and if that fails, go for a conjunctival graft, which may be from the adjacent or the free conjunctiva, or a pedicle graft. So let's discuss a few cases. Now this is a case of bilateral advanced steroid-induced glaucoma. He's a, say, 58-year-old male on brimonidine and timolol and Dorzox with lubricants since 10 years. Recently for IOP control, prostaglandins were added. And within 10 days, this patient comes with severe redness, watering and pain. So I see a lot of postgraduates sitting here, which is so good. What are the possible contributions that you think are causing these signs and symptoms? Is it drug allergy, toxicity, dry eye, meibomian gland disease, or preservative toxicity? Anyone? All right. So this is because because of a particular agent that you've just started. This is actually a drug allergy manifestation. So you discontinue the allergen, which in this case was bimatoprost, and probably shift them to another agent and treat coexistingly the lid and the ocular surface. All right, this is the second case. 65-year-old female, both have advanced glaucoma, as you can see on 4 AGMs. Recently has decreased vision, blurring, decrease of line, 2 lines vision, but the cupping is stable and the intraocular pressure is well controlled. Schirmer test is normal and moderate MGD is present. As you can see over here, you can see multiple punctate erosions. What would you think is the next step for such a patient? Would you like to change to preservative free? Would you like to decrease the backload, give them anti-inflammatory therapy or punctal plugs? Or all? All. That's the right part. So this is the patient on a lot of medications for a very long time, probably has drug toxicity because of the medication they've been using. So switch to combination, decrease the backload, give preservative free, and also add the anti-inflammatory therapy. So as you said, steroids, for example, and as I said, lifitegrast has a role in such patients, and also coexistently treat the MGD. So in summary, incidence of OSD in patients is very high. This affects the adherence and the quality of life and quality of vision. So it is extremely important to treat the OSD in glaucoma patients aggressively and to start early, which improves both the surface and the IOP, and the number of drugs actually contributes. So be careful while writing that prescription. Some topical drugs are better, like the preservative-free, and special delivery systems may be looked for. Alternative options should be searched for, like laser or patients who should undergo MIGS. Thank you so much. Thank you, Kirti ma'am, for this opportunity.
So we have covered the phenotypes in children, we have covered the MIGS role, and now we've covered the medical management and the problems it has. Now let us go to something which is uniquely Indian. Can I have my slides, please? Dr. Kirti Singh, aage beta, I have it. Mil gaya. Thank you. Yeah. So something which is, we talk about angle closure glaucoma now more importantly. So the topic given to me was the lens and iris parameters in ACG management and how do they define. So glaucoma, we know in Asia, more than 3/4 of the angle closure population is in Asia, and in India we are sitting at a volcano of angle closure glaucoma. Study from our center, angle closure glaucoma comprises 50% of the glaucomas, and many of them come to us with blindness. And the dependency on escort is there, self-earning, obviously Ayushman is coming in, but there's poor access to healthcare. So all these facts and the fact that lens vault is invariably high, which worsens the angle clouded in predisposed eyes, which we found that in angle closure it was almost more than 2 times. Like this is the lens vault in angle, open angle was 0.36, whereas at angle closure it was 1.06. So we really did find that exaggerated lens vault or the volcano configuration as it is described, which is more than 1/3 of the distance between corneal endothelium and the scleral spur line, is an independent risk factor for angle closure glaucoma. The other fact of iris, which is established since our post-graduation, we've been reading about the sphincteric atrophy, the whirling, the ectropia on UVA. We know all that the iris close and angle closure glaucoma are many. What we now need to know is, in addition to that, we have something called a thick peripheral iris roll, or the PIR, which is a problematic situation, and in those situations the treatment will vary. When we went back to literature, we found that Quigley had long ago said that iris is a sponge, which is a cause of angle closure, and this has now come up more after the imaging devices has come in. Now, all these iris parameters of curve, area, thickness have been independently associated with narrow angles after adjusting for age, gender, and and anterior chamber depth. However, there's a difference in opinion. Some studies from Asia have said that iris curve is more, and the gentleman sitting with Dr. Arun, studies from Singapore have said that iris curve is more, iris thickness is more. Yes, Arun? But the Indian studies from Dr. Sehota et al. Said that the iris thickness is less in ACG. So let's look at a few of these studies from the Singapore group of almost 1400 eye studies in different Chinese, Indians and Malays said that lens vault of more than 667 was independently associated with narrow angle. However, from the same center, when they did only Chinese studies on only in Chinese patients, they said again the lens vault was significantly higher, but the angle closure odds ratio was much higher, and lens thickness was not associated with angle closure glaucoma. A group from South Korea on Asian eyes talked about the relative lens vault, which had the highest Oro curve. So they recommend that building up of the normative database as a screening tool in predicting the potential risk of angle closure is important. Increased iris curvature, less iris thickness was the study from Iran, and where they said the steeper iris was independent factor which predicts the angle widening post LPI. So things have been evolving since our times when we had read that steeper iris, more curved, okay, angle closure. And this, the thing which I was talking about, the study was about thick peripheral iris roll, which has a prominent circumferential folds. In that case, in addition to plateau iris, in this situation also the PI would be ineffective. And we all know about the Eagle study where the exaggerated lens vault obviously is a predictive of angle closure, so there's a role of lens extraction. So what have we understood from all these studies till now? That there's an ethnic variation which was again clarified by the study from the Spain group. So coming from all these studies, we came to the Indian study. Let's talk about the lens parameters and iris parameters specifically. So we studied group of 81 eyes who required cataract and combined surgery for angle closure glaucomas vis-a-vis age-matched open-angle glaucoma eyes, and we found that lens vault was significantly more in the angle closure glaucoma eyes, and the lens thickness was similar in both the eyes, and the relative lens vault was also very much different. So this was like echoing the previous studies where lens vault and relative lens vault and not lens thickness was significantly increased in angle closure glaucomas. Few of the case vignettes we can show you. This is the lens vault in angle closure glaucoma, and you can see the lens vault in POAG. So it is very obvious now when you start looking for it. And when you start looking for it again, if you go back on the slit lamp, you will find that this is a volcano configuration. So once you had imaged them, you started looking for them. Iris thickness, again we found that the iris curve and iris area was surprisingly in our patients decreased, which was not expected. We'll come back to that later. So lens parameters we also studied in angle closure vis-a-vis just plain operable age-matched cataract patients. And no surprise here, we did find that the lens thickness was more and the lens vault was significantly more and the relative lens vault. So similar findings in compared to cataract alone, compared to the age-matched cataract. These are a few of the case vignettes of the PSCG eye and the age-matched plain cataract eyes. But in the iris parameters, the iris curve, why was it less? We went back to our data and we found that maybe it is less because the PI was done for all these patients, and post-cataract surgery, there's a flattening of the iris curvature which is contributing. So it's dynamic. It's just not that it is a simple, the iris curve is more. Once you do a PI, things do change. So we found, like the other study, that we had a thinner iris at 750 microns and 2000 microns, and this was reduced, both of them were reduced post cataract surgery. So going back, in Asia itself, if you are looking at Chinese and Malays, you are finding that the iris curve and the iris thickness is more. If you are looking at Indian eyes, the iris thickness is less. And how does it matter to all these matter? Because the surgical outcomes are different. Like you can see now, this is a volcano configuration, and the capsular rhexis in a ACG patient is a different ball game vis-a-vis in an open angle glaucoma patient. And this is a very high lens vault, almost 0.9. Till now we've done up to 1.5. And you can see it is and this we don't have heel on, so this is more difficult. Other thing we found that the iris behaves differently. There's a floppy iris like thing which is seen in tamsulosin, and it keeps coming out during surgery. So sometimes you have to do a small surgical PI to prevent this constant billowing of the iris. And in addition, for failing filters in angle closure glaucoma, when we do cataract surgery, we also do an intra-op needling with an ab interno revision, like I'll just. So once the suture is placed, this filter was there, in which we are doing now a ab externo needlings to revive the bleb, because post surgery the blebs do fail. Another thing which we noticed in our patients was that the iris bleed was more common in angle closure glaucoma, just like the Amsler sign in Fuchs. We've been finding this in glaucoma and angle closure glaucoma patients. So to conclude, how is the surgical outcome redefined after finding all these iris signs and the lens signs? We correlated our IOP control post phaco or phaco trap with the iris and the lens. What we found as that just in angle closure glaucoma with phaco alone, it could reduce the IOP over 4 months by 6.7 millimeters of mercury, and even the the requirement for medicines reduced. And it was related positively to the iris curve and negatively related to the iris thickness at 750. So what does that mean? That lens is bulkier in ACG. We know that, that's a no-brainer now. Relative lens vault is a more sensitive marker related to angle closure. Iris parameters after phacoemulsification, not only do the iris curve reduces, but the iris thickness also reduces. The steep iris configuration from 37% pre-op reduced to 13%, and as expected, there was a significant reduction in the ITC index in the ACG cases. The predictions of IOP control was there was a positive correlation with the pre-op eye curve. More the eye curve, more steep the iris, more was the post-op reduction. Negative correlation with the iris thickness. Thicker the iris, lesser the post-op IOP reduction. And there was a positive correlation with the pre-op ITC index and lens vault both. So bulkier the lens, more the ITC index, more was the IOP reduction. So what do we end with? We have a large proportion of angle closure glaucoma patients in Asia. Relative lens vault needs to be looked at more, and this can predict the IOP control. We need to start looking at the volcano configuration and start planning lens correction along with the trabeculectomy. We need to generate normative lens vault databases, and iris is important not only in the anatomy, the physiology of iris is different. It's a culprit in angle closure glaucoma. We have a fat, bulky lens with a floppy, flaccid iris, which often bleeds. So both phenotype and the behavioral characteristics are different. So to conclude, even in these studies from Asia, from let's say China, Singapore, and India, are showing different ethnicity. Thank you. So we have Dr. Arun, who will be talking about something which he has devised. He'll be talking about the role of lasers in angle closure glaucoma, a very unusual topic. Over to you, Dr. Arun.
Thank you, AIOS. Thank you, Dr. Kirti, for organizing this course. I'm just going to give an overview of some of the alternative lasers in angle closure. The ability to use laser as a non-incisional therapeutic modality is immensely magical. We've been using these for decades and generations, but I think this is a good point to step back and acknowledge these two individuals, Dr. Rosa and Dr. Francis Las Prince, who gave us these lasers. More importantly, I want you to focus on the statement of innovation by Rosa, who said that an innovation doesn't come from sudden illumination. It requires a time of observation, a certain inclination to gamble, and the feeling that the present is already the past. So this is really a message to take home, to start thinking about what you're doing so that we can improve what we do at every point in time. So just to give you an overview of what lasers can achieve at the, in terms of countering pathology at various physiological levels, is, as far as angle closure goes, is it helps us relieve pupillary block by doing the iridotomy, allows outflow enhancement in the form of once we do the iridoplasty and trabeculoplasty, and inflow reduction when we do cyclophotocoagulation. Just the overview of iridoplasty is that typically it is indicated when there is persistent appositional angle closure following an iridotomy, and there is raised IOP, or this progressive synovial closure, or a situation wherein we label as plateau iris syndrome. Further applications are in situations such as acute primary angle closure glaucoma and lens-related angle closure glaucoma. These are the settings which most of you are aware of. The aim of the therapy is to achieve contracture of the iris like you see in this video without extensive charring, and hopefully the angle recess opens up following the procedure. So in general, I told you about the overview where iridoplasty can be applied. Some data on how effective it is as far as acute primary angle closure goes. Good data from Dennis Lam and group, who performed iridoplasty in 73 consecutive angle closure eyes. Basically, they were randomized to either iridoplasty or medication only, and the authors found that iridoplasty was able to achieve an intraocular pressure drop that was nearly a lot more rapid than medication could, and intraocular pressure was lower at various time points until up to 2 hours earlier compared to medication when iridoplasty was done. So they did conclude that it's a safe and effective alternative to medical treatment for acute primary angle closure. Some of the pros are the ability to thwart IOP at an early stage, earlier symptomatic relief, lower risk of medication-related side effects, and lower risk of permanent synovial closure. The complications are the cons are, however, damage to the endothelium, Urey-Zavari syndrome, and we have to understand that iridoplasty alone does not eliminate pupillary block. In terms of other scenarios, such as primary angle closure glaucoma, the effectiveness is about 60%, and similar in plateau iris syndrome, and also effective enough in phacomorphic glaucoma. Our own trial from Singapore, wherein we randomized about 40 eyes in each group, we noted that the survival rates at 1 year was close to 60% following iridoplasty compared to about 87% when we treated them medically. See, the overall effectiveness of angle closure is lower, of iridoplasty in angle closure is lower when compared to prostaglandin therapy. It is a useful surgical therapeutic modality in certain indications such as plateau iris syndrome, and selective application in acute primary angle closure, phacomorphic, and so on. But with the immensely improved cataract surgical skills, iridoplasty may have very selective applications in our armamentarium at this point in time. So moving on to selective laser trabeculoplasty, the selective laser trabeculoplasty B has been hovering around for many decades, but the uptake as a standard option in a therapeutic armamentarium remains low, but things are changing. We all know that the role of medical management and its effectiveness is irrefutable, but it's intertwined with challenges such as poor adherence, systemic side effects, poor quality of life, and negative impact from the success of subsequent surgical intervention. These challenges are similar to open angle and angle closure disease. The 6-year outcomes of the LIGHT trial is rather positive in terms of its outcomes, wherein they noted that there's lower disease progression in SLT, 70% of the subjects were drop-free after SLT, and there are more incisional surgeries that were required in the medication form. This could be similarly applied to in our management of angle closure disease. Our own data about SLT in angle closure, when we recruited about 50 eyes in each arm and randomized them to SLT versus medication. All of these eyes had an iridotomy in at least 180 degrees of open angle, and the IOP response was noted similar at 6 months between the SLT and the medication arm. The overall success rate was close to about 60% in the SLT arm and about 80% in the medication arm. So in general, it is an effective therapy. The mean IOP reduction with SLT was equivocal to prostaglandin therapy at about 6 months. Now we move on to the innovative aspect of this laser that is probably that will probably be accessible to many of us. This restless innovator, Professor Michael Belkin, most of you would know, identified the main pain point, that is gonioscopy, and he he thought about a way to eliminate this as part of the SLT procedure and came up with the platform of direct SLT, wherein you can deliver the SLT to the angle without any gonioscopy. It's basically a quick Q-switch laser. It has an image processing algorithm that locates the target area on the limbus, and it's able to deliver about 120 laser pulses in under 4 seconds to all around the limbus. So we'll see a video of this that will probably be more informative on how the technology works. There audio to the video?
400-micron beam on the limbus, and as the laser energy penetrates the ocular tissue, it scatters, forming a cloud of energy reaching the trabecular meshwork. To better understand, let's look closer. The typical energy delivered per pulse is higher in DSLT than SLT. In DSLT, the energy is directed through the limbus, and in SLT via the cornea. DSLT allows energy to scatter throughout the tissue, resulting in lower energy transmission to the trabecular meshwork. Energy per pulse reaching the trabecular meshwork is similar in both therapies. Multiplying this energy by the number of spots per treatment would result in a similar total energy reaching the trabecular meshwork in both therapies. The resulting effect is a lowering of intraocular pressure. DSLT offers a sophisticated non-contact therapy, effective as a first-line treatment for glaucoma and OHT.
So this is from our trials where we've been able to deliver the SLT in a very quick and efficient way. You notice that the delivery can be done either with the patient standing or seated, and from now, you know, the therapy is completed. It's delivered about 120 shots of laser without the aid of gonioscopy. So the current evidence is very limited. The Glorious study is an RCT that compared DSLT with SLT. They noted that the overall reduction was very similar in both the arms, and it is currently FDA approved, and you probably hear about its launch very soon. In our own trial of DSLT in angle closure disease, especially in eyes that have been iridotomized and at least 180 degrees of open angle, the effectiveness, which is indicated by the green line at 4 months, was pretty effective. We noted that the intraocular pressure drop ranged from about 25 to 36% at about 4 to 6 months, and 76% of the subjects have remained medication-free. About 38% needed retreatment, and overall, the SLT has demonstrated immense potential to keep a patient drug-free. The ease of effective laser delivery through the DSLT has opened up an exciting era for glaucoma management. The costs and logistics of the management of using SLT as a routine therapeutic option may not be feasible for every healthcare system, but appropriate case selection and application of laser widens our armamentarium to manage angle closure effectively. Thank you all.
Thank you, Dr. Arun, for that eye-opener of new things being done with laser in angle closure. We'll leave the time for the questions later. We have Dr. Anu June, who will be talking on, now we come to the therapeutic aspects of combined lens and glaucoma surgery in advanced angle closure glaucoma.
Thank you, ma'am. So I think my job has been made really easy with the talk that Dr. Kirti Singh has already given about the role of lens and the parameters such as lens vault and iris curve and iris thickness in angle closure glaucoma, and made further easy by the talk that Dr. Siddharth Dikshit has already talked about, the role of MIGS and combining it with phacoemulsification in all the studies and videos that he's already shown you. But let me summarize it once again for all of you. So the role of combined surgery, we need to assess what are the treatment challenges when we take up a patient of advanced PSEG or any angle closure glaucoma, the indications of such a combined surgery, the techniques that we have to adopt, what are the benefits that this combined approach gives to us, and the challenges and the risks associated with it, and the latest, that is the phaco-MIGS in angle closure glaucoma. The disease burden of PSEG, like Dr. Kirti Singh highlighted, as for the world account, PSEG accounts for almost half of all the glaucoma blindness worldwide, and Asians account for more than 3/4 of the PSEG population. So it's quite rampant in our Southeast Asian community. And talking about the Indian scenario, we have 11.2 million persons aged 40 years and older in India with glaucoma, of which PSEG affects 2.54 million. Now, the treatment challenges are multifactorial in nature. If we talk about an older age, most of these patients are complicated with a coexisting cataract, higher IOPs, and an advanced optic nerve damage. In younger age group, we face challenges with a clear lens, that is the high lens wall that we've already talked about, and shallow anterior chambers, which may predispose to post-trabeculectomy sequelae and a long dreaded post-operative period. When we talk about the limitations of the traditional treatment approaches, if we take up cataract surgery alone in these patients, they may not lower the IOP sufficiently, especially when we tailor the approach in cases of advanced ACGs and the kind of patient profile that comes to us, who have advanced damage with very high IOPs, sometimes in 40s and 50s. Glaucoma surgery alone may control the intraocular pressures, but the sequelae, we always talk about the post-trabeculectomy sequelae and a long post-op period that we have to follow up the patient for when we compare it with phacoemulsification. And these sequelae with shallow anterior chambers in a pre-existing shallow AC can be dreadful. Also, these patients already have a very tunneled vision with advanced damages and macular splits on visual fields. And that some amount of cataract progression may also affect their functionality significantly. So a combined approach gives a more holistic solution to these patients. This is a picture of a patient who underwent a trabeculectomy in a ACG patient. He had some amount of cataract, didn't appear to be significant to us initially, but as you see, the chamber is very, very shallow. In the center picture, you also see that the peripheral iridocorneal touch, it's just sparing the peripheral angles. It's already VH grade 1. And on down gaze, it appears as if there is a touch, although there wasn't. So cataract progression can occur really rapidly in these eyes if we do not adopt a combined approach. A lot of journals have focused on the impact of early lens extraction in the treatment of ACG, like the EAGLE study. But the disadvantage here is that they've compared it with standard care of laser peripheral iridotomy and topical medical treatment. That may have an effect in cases of early to moderate ACGs, but when we talk about advanced ACGs, just a laser PI and topical treatment may not be able to achieve the target IOP. The studies who focused on with combined phacotrabeculectomy are mostly associated with medically controlled angle closures. So if a patient is controlled on medications, we can still tailor our approach more or less around phacoemulsification. But when we talk about uncontrolled glaucomas, trabeculectomy has to be done. Studies also have compared phacoemulsification versus trab in medically uncontrolled, and they found out that trabeculectomy treated eyes required on an average fewer drugs than only phacoemulsification eyes. Why do we fear this trabeculectomy so much? Trabeculectomy, as they concluded, is definitely more effective than phacoemulsification, but is associated with more complications. But a well-done surgery and a well-followed-up patient can help us prevent these complications or manage them better, but our primary aim has to attain the target IOP. The kind of tailored approach that we have to focus on the patients, our patients are mostly who have very advanced glaucomas, a 0.9 cup. They present to us already in the stage of relative afferent pupillary defects, tunnel visions, macular splits. There are issues with medical compliance because they don't understand what they're gaining. They say, when did I take my medication last? They don't remember. They have forgetfulness issues. There are cost issues associated with the same. And of course, they're not seeing any improvement in that already damaged visual fields or the functionality. So they feel it doesn't really matter until they worsen further. Hence, the importance of combined surgeries. Our goal has to be primarily to reduce the intraocular pressure, but also preserving the vision or improving where we can by removing that even smaller or insignificant amount of cataracts. You have to minimize the need for multiple surgeries because these patients may not come back to you unless the cataract has progressed much harder, and then there are risks of trabeculectomy failures in those patients when we operate them again. Dr. Kirti ma'am has already talked about the role of lens vault in these patients, and further shallowing may happen if you do just a trabeculectomy. So in cases of cataracts, you definitely need to remove them, but in clear lenses with high lens vault or lens thicknesses, again the role of lens handling becomes important along with trabeculectomy. Field medical management is again an important indication, and higher IOPs along with some amount of cataract progressions. Talking about the surgical techniques, we can go in for a single site approach wherein you do a phacoemulsification along with trabeculectomy at the same site. However, we generally prefer a two-site approach wherein you open up you make a flap superiorly, do a phacoemulsification from the temporal incision, and then go back and complete your trabeculectomy in the superior site. This has shown to have higher post-operative success compared to same-site trabeculectomies. The benefits are that there is improved intraocular pressure control, enhanced visual outcomes. That slight gain of vision or slight improvement in contrast goes a long way for these patients physiologically and functionally. Challenges, however, again, are the increased surgical complexity. Even doing a plain phacoemulsification in these eyes is not easy. You encounter high convexity of the lenses, difficulty in the rexes, and iris prolapses in these patients. However, the future now is also phaco combined with MIGS, like Dr. Siddharth has already talked about. But what are the challenges that we face in this? The most important challenge is the direct gonioscopy, which is a diagnostic tool. So I would encourage all of the audience sitting here, even when you're doing a cataract surgery in an open angle or a normal phaco patient, make your patient lie down on the table, tilt their heads, turn the microscopes, at least try to visualize how an angle looks on direct gonioscopy. Maybe go in with your blunt cannulas, try to touch those structures at the angle, so that when you encounter an open angle or an angle closure glaucoma patient, you have the caliber to operate on these procedures and do a successful MIGS. So learning a direct gonioscopy is really important and goes a long way in performing these surgeries. The indications, however, I would say should be medically controlled ACGs. Uncontrolled and advanced ACGs should be reserved for trabeculectomy. Surgical challenges again are the shallow ACs, which will hamper our management, but they may be performed after lens removal. So once you've done a cataract surgery, the angles open up and gives you enough space to perform a MIGS. Studies have compared long-term outcomes of combined phaco with KDB in different subtypes of glaucoma, and they found out that in ACG eyes, mean baseline IOP had decreased by 23% and the number of medications by 56 to 87%. And this is how an angle after a KDB looks like sometimes. Even in ACGs, the angles open up really nicely. There have been no documented studies of bent angle goniotomies along with phacoemulsification in ACG as far as I could do my literature search. But we are already doing a study under Dr. Kirti Singh in Guru Nanak Eye Center, and we've had promising results so far. And this is how nicely the angles sometimes open up after bang even in ACGs. Studies have also been done on chronic ACGs with phacoemulsification and ECP. And they've also found out that the IOP reduction was 26.2% in the ECP group. And the ECP group, which did not undergo goniosynculisis, had less pars formation. This is one of the surgeries highlighting ECP, and the advantage it gives is that you can bypass that angle and you go behind. So once you've done your lens surgery, you visualize the ciliary processes and you can coagulate them. This is a 360, almost a 270-degree view of how these coagulated ciliary processes look like. GAT has also been combined, and Dr. Siddharth has shown a beautiful video of GAT being done in ACGs. So I would like to conclude by saying that the approach has to be extremely tailored. If you have advanced glaucomas but medically uncontrolled pressures, go in for a combined phacotrabeculectomies or tubes. However, if you have controlled glaucomas, like in the range of maybe late teens or early 20s, on anti-glaucoma medications with compliance issues or side effects, phaco-MIGS can be a way for you. Thank you so much.
Thank you, Dr. Anu, for covering that up so beautifully. We have now, we reserved the best for the last. Dr. Sunita, who is a very versatile surgeon, and she has a maximum experience in something which we see very frequently, secondary angle closure glaucomas. Over to you, Dr. Sunita. Mike, audio vision, please.
Hello? Yeah. So surgical and non-surgical options in secondary angle closure glaucomas. So as we know, secondary angle closure glaucoma occurs due to ocular or systemic conditions, either pulling or pushing the iris forward. It can be without pupillary block or with pupillary block, and we have so many conditions which are associated with secondary angle closure glaucoma. So since it's a very vast topic, I'll be just covering a few of them. Neovascular glaucoma is one of the commonest glaucomas we've seen, and we know the most common causes. It is because of the retinal ischemia leading to angiogenic factors release, NVI, NVA, formation of fibrovascular membrane, and then leading to complete angle closure. So most of the advanced neovascular glaucomas, when they come to us, they have very high intraocular pressure, NVI extensively, and with ectropion, uvea, and completely closed angles. So the management goals is to control the retinal ischemia and control of intraocular pressure with control of inflammation. So basically it's a co-management by the glaucoma and retina specialists. So most of these patients often require maximal medical therapy, and the pressures are still not controlled with that, and sometimes we have to resort to cyclodestructive procedures, graded TSCPC or micropulse to control intraocular pressure, so that we can perform PRP before taking up the patient for definitive glaucoma surgeries. So as far as the surgical management is concerned, trabeculectomy or glaucoma drainage implants can be done. Success of trabeculectomy has improved with the use of MMC, prior good PRP, ARC, and intravitreal anti-VEGF injections. However, long-term success is not so good, and failure could be because of the severe inflammation and hyphema. So I would like to discuss this case who had bilateral NVG with uncontrolled glaucomas, and this patient had this epithelial defect. Both eyes had persistent epithelial defect. He had on maximum medical therapy, and even conservative management was not effective. So after doing the trabeculectomy was combined with the AMG in this patient. So after doing trabeculectomy, the epithelium was peeled off and cauterized so as to remove the epithelium completely, and then AMG was placed over the cornea, and the fibrin glue was used to stick the AMG over the cornea. So in both the eyes, the surgery was performed. As you can see, the fibrin glue was used. So this patient did really well post-operatively, and after this, contact lens was applied. So this patient has been following up with me, and the epithelium is completely healed, and he's been doing well in both eyes with good vision and IOP controlled on 1 or 2 medications. GDD is widely used in neovascular glaucoma patients, and this particular patient, after failed TRAB, the AGV was done. AGV is preferred because you want to reduce the pressure immediately, and one has to remember that the insertion of tube is very important, and the tube should be inserted. You can't, because of the extensive PAS, you can't insert the tube into the anterior chamber. So this step is very, very important, and this will allow safe surgery. Another common condition is ICE syndrome, and we know it's a spectrum of diseases which is characterized by corneal endothelial abnormalities, and we see all kinds of disease in the spectrum, and in India we see a lot of essential iris atrophy. So this particular patient, young female patient, the right eye was more or less normal, but left eye had ICE syndrome with iris holes, stretched iris, correctopia, polychoria, and broad-based PAS all around, as you can see. So TRAB was done, and even aqueous sample was sent for CMV, which was found to be negative. So the TRAB worked for 2 years, and then as we followed up the patient, we could see that these nodules, developed over a period of time. That means the disease was progressing. So this is a progressive disease, and that is why over a period of time the pressure control is also lost, and the pressure also became very high. She underwent micropulse, and then we advised her tube implant. So if you look at literature, the long-term surgical outcome of these patients is not so good, and multiple procedures are often needed to control intraocular pressure and even keratoplasty. The third condition is malignant glaucoma. Again, we see them a lot, And here you have to rule out the pupillary block glaucoma, and there is axial shallowing of the anterior chamber. It is secondary to the incisional surgery after angle closure glaucoma. UBM is diagnostic. So we know the principles of management of malignant glaucoma. To begin with, we start with the medical therapy. Cycloplegia is a must. We use a combination of atropine and phenylephrine, and if they do not respond to medical therapy, then if the patient is pseudophakic, we try laser hyalodotomy and disruption of the anterior hyaloid phase with laser capsulotomy. You can even do TSC-PC. At the last resort, you can do vitrectomy. In phakic patient, you have to remove the lens and vitrectomy. This particular patient again was referred to us, was a case of malignant glaucoma not responding to medical therapy. So we did IZHV, which is now getting very popular, and this, as you can see, through the iridectomy, we did the zonulectomy and hyalodectomy, and however, to our surprise, the AC was still shallow, but when we carefully examined the patient, there was a membrane which was covering this iridectomy, and we did YAG iridotomy or membranectomy to relieve or to release the block, and then the patient did very well. So this procedure, literature also suggests that in pseudophakic eyes, IZHV was associated with pure recurrences. Uveitic glaucoma is again common, and these are the conditions which we seen routinely, and again the management to start with is a medical management, and patient later stages develop PAS, maybe complete PAS and iris bombay, and sometimes there is edema of ciliary body and anterior rotation of the ciliary body. So management to begin with is medical management, YAG, ND-YAG, PI for iris bombay, and then you can perform any of these surgeries. Tube implants are preferred procedures. Trabeculectomies should be avoided in patients with active inflammation, neovascularization. MIGS again can be used. This was one patient with uveitic glaucoma. So goniosynecholysis was done. So just separated the synechia with iris repositor, and then KDB was performed. So these procedures are said to be effective in uveitic glaucoma, which are not very advanced and which are associated with cataract. So I cannot cover everything, but yeah, in PK, just one thing is that it is common even after DSAC, and chronic synechial angle closure can be the cause of long-standing glaucoma. To begin with, we start with the medical management and surgical management. You can do trap, tube, anything. So traps have better long-term survival. However, tubes have better IOP control. Cyclodestructive procedure sometimes we have to resort to. However, after doing any kind of invasive procedure, it needs to be remembered that there is increased risk of intraocular inflammation and graft failure. So whenever you are doing any surgical procedure, you have to step up the steroids and continue the steroids for long. And TSC-PC, if you have to, you decide, do it in a titrated way to reduce the risk of hypotony and inflammation. So to conclude, management of secondary angle closure glaucoma focuses on addressing the underlying cause while controlling the inflammation and intraocular pressure. And of course, because there are so many conditions, a tailored approach should be based depending on the etiology and disease severity. Thank you very much.
Thank you very much, Dr. Sunita, for covering that such a vast topic. And now it's my pleasure to call on the dais talk to us about the glaucoma, the hidden scourge of uveitis. Thank you, Dr. Mark, for coming to our country.
Thank you very much. It's a pleasure to be here, and it's an honor to follow you. You've given fantastic presentations. I'm in fact a uveitis specialist, and I do more retina, so I've learned a lot about glaucoma. But my job here in some ways is not to teach you how to do the surgery or maybe how to treat uveitic glaucoma, although maybe I can give you a few tips. It's more to be able to put it into the appropriate perspective. If you could open my presentation, or maybe I'll do it. No, 1 second.
Audiovisual, please, Dr. Mark's presentation. Did you load it, sir?
Yep, yes, there it is.
Okay.
So these are my disclosures. They're not really important with regards to this. And I thought I would start with two cases. So the first one is a 48-year-old man that was seen, I practiced in Switzerland. He had high IOP and granulomatous uveitis in both eyes, even off steroids. He had 2 GAT procedures, one in each eye, and yet the pressure remained high. Now, in this part of the world, you probably would recognize what this is because this is CMV anterior uveitis. It responds very nicely to antivirals. In fact, with acyclovir, his pressure dropped. And it shows how we do need, as was mentioned before, collaborations between glaucoma retina specialists, definitely between glaucoma and uveitis specialists that is required. The second case is a patient that came to see me with HLA-B27 uveitis. 2 years before, she had cataract surgery. Everything went well. She was placed on an anti-TNF agent because she had active disease. Too expensive for her, she stopped. And whenever she had a flare-up, she would put herself on steroids for several weeks. When she came, she had hand motions in the right eye, 0.5 vision in the left, high IOP, active uveitis in the right eye. We weren't able to get a visual field in the right eye. There was definitely a limitation also in the left. And if we look at the RNFL in this case, oddly enough for the right eye, there still seems to be a neurofiber layer. But once the uveitis is gone, all of a sudden we have nothing. And I think this is one of the other aspects, is if you're dealing with uveitis patients and you do your standard exams, some of them give you a false sense of security, in part because we get retinal edema, and that retinal edema will make it so that your RNFL doesn't really give you the full picture. So we all know glaucoma is a chronic progressive disease. We can monitor intraocular pressure, optic nerve, and the RNFL, as well as other modalities. And in uveitis, it's associated with essentially the presence of inflammation. And for ocular hypertension, we usually use 21 to 24 as being the threshold, but is this in fact correct for uveitis patients? And what I'm going to try to tell you now, out of studies that were done in the recent past, is that in fact you should be extremely sensitive to the fact that if you have inflammation, any increase in intraocular pressure may already give you problems. Of course, one of the key elements is the treatment we use. We have to use steroids, usually at the very beginning. Our role as uveitis specialists is to try to switch them over as soon as possible to immunomodulators if they have persistent disease. But as I've just shown you with the second patient, is we can't put them on good immunomodulators, but if they're too expensive, they stop and they go back to what they received initially. And corticosteroids, yes, can give you increased pressure. They will do it in all patients without a patient being a steroid responder. Steroid responders with 1 drop will go up into the 40s. It usually takes about 7 to 8 weeks, but can occur as soon as 3 weeks of use. For example, with dexamethasone, the pediatric population is a lot more sensitive and you have to be a lot more careful. If you go beyond 2 drops, they can have increases in pressure. And if there is oral steroids being used at the same time, then the risk is much higher. So 31% over a period of about 7 to 8 weeks will have an increase in pressure, and about 10 to 15% will even go above 30. And if you follow patients long enough with uveitis, at some point there will be an increase in pressure. And it wouldn't be surprising that within 5 to 6 years, these patients will be over 21 millimeters of mercury. And as I'll show you in some from other studies, in patients that were followed in the MUST trial that used the Osidex in one eye and followed patients with systemic therapy in the other, any patient that had an intraocular pressure over 16 had a risk of developing glaucoma. Now, increase in the number of drops certainly will increase the risk of having a pressure rise. Certainly, if you go to higher numbers, for example, 5 to 7 drops per day, that rate can go up, the relative risk will go up to about 8. Now, there isn't much difference in terms of the need for control of pressure with drops, whether you're using a periocular injection well placed without any reflux, whether it's an intravitreal injection or dexamethasone drops being placed topically. There is an increased risk by about 7 to 8 weeks, as I've mentioned, and more of these patients will require over that initial period of time where they need to be followed the use of drops. There are other factors, if there are posterior synechiae, anterior synechiae, or the length of treatment that increase the risk of developing glaucoma, so that has to be taken care of and taken into account. And these are the results of a study that in patients that were followed with either systemic or the implant, the MUST trial. You'll notice that a number of these patients were already on glaucoma medication drops at the very beginning of the study, 13% in the systemic group as 17% in the implant. They had good cup to risk ratios, and in fact the visual field mean defect was 4.8 to 5.7, a mean of 5.2. I mentioned that because after 2 years with systemic treatment, you see that you have about 26% now that have developed a pressure increase that requires treatment in the control group on the systemic side, where we had only 13% initially, and 69% when an implant was placed into their eye. So the use of an implant certainly increases the risk of glaucoma, that's well known. There's also an increase in the need for surgery. And this is progressive over time, particularly in the group that receives an implant. You can expect that glaucoma surgery will be required somewhere between 12 to 18 months after entry into the study. Now, that's not the only problem, because if glaucoma develops in uveitis patients, they tend to progress more quickly. As you can see here, the relative risk for uveitis glaucoma patient to be a rapid progressor is 1.9 as compared to a chronic open-angle glaucoma, and the rate of progression tends to be faster. This is this study that was done in Britain. If we look again at the MUST trial, you'll see that in fact the glaucoma group had a mean visual defect at 2 years of about 12, when initially we were at 5.1. So that represents about a progression of 5 dB per year over that 2-year period, while in the non-glaucoma group, the progression was about 0.5. So progression is quick. Patients need to be followed very carefully. But if they're well treated, as was mentioned earlier in the previous presentation, you can in fact stabilize the situation as long as the patient is followed sufficiently. So there is a higher rate of progression. There's also an increase in the cup to disc ratio. And for that reason, a group of uveitis experts as well as glaucoma experts got together about 2 years ago, and we've been discussing since what would be the best way to follow patients. Well, at this stage, we all agree that tonometry is important at each visit. Gonioscopy should be done on all uveitis patients at least once to get an idea of what the angle looks like, and whenever there is a recurrence of inflammation, because you can accumulate either synechiae, granulomas, or otherwise fibrin that goes into the angle and may compromise and make the uveitis worse. Similarly, I've shown you RNFL can in fact give you a false sense of security if there's active disease, and so you need to establish a baseline from which you know more or less what the situation is when there is no uveitis present in that eye, and then should be followed at least on an annual basis. Similar visual field should be done frequently enough to get a baseline, and then depending on whether there are any signs of glaucoma or visual field changes or NFL changes, then you should go from doing it annually to more frequently. And finally, optic nerve head photos are always useful. They're easy to obtain, and I think in most settings should be done. With regards to therapy, ocular hypertension in uveitis is not 20 to 24, it's a lower pressure. Any increase in intraocular pressure associated with the changes that would typically appear in glaucoma should indicate the presence of ocular hypertension, and you should treat aggressively to reduce that pressure to the lower teens, essentially as a bad glaucoma patient, because they progress more quickly. Similarly, and this should probably best be done in close collaboration with our glaucoma experts. With regards to surgical therapy, we don't really know at this stage what the best approach is. If you have a person that knows how to do trabeculectomies well, I think it's a good procedure. Certainly if the patient has no inflammation, the inflammation has to be under good control. MIG certainly function. Ceton placement is certainly something that should be considered if it's active disease or if other modalities have failed, and there are different ones. AMED and the Paul valve seem both to be very good. Close follow-up is required. Treatment of the inflammation is naturally required, and the exact role of SLTs or excimer trabeculoplasties that isn't quite really defined at this stage, but certainly would benefit from further research because they're non-aggressive, non-inflammatory, and may be good ways to control pressure for the very same reasons that were discussed earlier today. So in conclusion, glaucoma is an unsolved issue really in uveitis, one that hasn't received much attention. Progression is fast, and we need to find a combined solution that will work for the future. The loss starts at lower intraocular pressures than might appear in chronic open-angle glaucoma. We need aggressive therapy, and IOP increase is not just due to steroids. So what is going to be your approach in uveitic glaucomas from now on? I leave that up to you. Thank you very much.
Thank you very much.
For those of you who are interested, there is a course being organized early June in Bruges in Belgium that will tell you everything about the basics of uveitis management, and we'll be talking about glaucoma also.
Great. Thank you very much. Can we have a group photo with you, sir, please?